Good evening, all the dignitaries and delegates. Happy Doctors' Day to all. Our Indian Academy of Pediatrics is the second largest body of pediatricians in the world. More than 40,000 members in India. And Maha-AP, our state branch, is kind enough to give importance to the academic activity started by one of its branch, Raigad IAP. Journal Journey is dedicated to emerging multidisciplinary field of neonatology and pediatrics with a scientific content of highest standards. The topics are relevant to be used by practicing pediatricians. Maha-IAP Journal Journey provides a platform for presentation of enthusiastic practicing pediatricians as well as postgraduates. We are working with best use of electronic media, and our guru in this activity is none other than our dedicated young Raigad IAP editor, Dr. Neha Singh. Over to Dr. Neha to welcome all the guests.
Thank you, Chitra ma'am. Happy Doctors' Day to everyone. Good evening, everyone. Myself, Dr. Neha Singh, and on behalf of Maharashtra IP and Raigad IP, welcome all the respected dignitaries, seniors, and colleagues for today's journal journey. I welcome Maha IP President Dr. Ram Gopal Chezara, Secretary General Dr. Amol Pawar, as well as all the respected executive board members of Central IP and Maha IP. I also welcome Raigad IP President Dr. Vikas More, Secretary Dr. Ajay Kohli, our patron respected Dr. Neeman Mohanty sir, Dr. Hemant Gangolia, Dr. Jay Bhandarkar, Dr. Chitra Kulkarni ma'am, and all the members from Raigad IP as well as other branches. I also welcome our both experts for today's session. Please note today's session has been granted 1 MMC point. So requesting everyone to type your name, MMC number, Central IAP number and city in the chat box. Dr. Vaibhav Pustake, Senior Pediatrician from Nasik, is our MMC observer. So will be joining us soon. We will welcome and acknowledge him as soon as he joins. Today, the journey of journal reading has completed its 3 years, and now how can we forget the names behind who started this journey? The doyens of journal journey, respected Dr. Hemant Gangolia sir and Dr. Jay Bhandarkar. So I request Gangolia sir, MAIP President 2022 and medical legal expert to give his blessings. Over to you, sir.
Thank you, Dr. Neha. At the outset, happy Doctors' Day to each and everyone on this dais, as well as the attendees of this Zoom webinar, and respected MAIP President Dr. Ram Gopal sir, as well as Secretary Dr. Amol, and then President and Secretary of IIT Raigad Dr. Vikas and Dr. Ajay, and the experts Dr. Neeman Mohanty sir and Ravindra Sonani sir, and pillar of this webinar or this journal journey, I can say Dr. Chitra Kulkarni madam and Dr. Neha madam, as well as all those who are there on this dais, and as well as the presenters, Dr. Avanti and Dr. Sadanand, both are there to present here. This is a special day. Exactly 3 years back, on 1st of August 2021, 1st of July 2021, we started this program of Journal Journey. Just it reminded of the article reading our PG days. So just the thought came across, and myself, Dr. Jay, Dr. Chitra madam and Dr. Neeman Mohanty, he was the person who guided us and how to start this journey, and that started Journal Journey. And then it went on long way, because it was continuing my tenureship of 2022 as well as the tenureship of Dr. Ramakant Patil sir in 2023, and we are very much grateful Dr. Ram Gopal sir also to continue this journey in his year also as 2024. So this is special, and it gives me immense pleasure that what we started is now we are entering the 4th year. So with that and everything started, of course, and all people joined, and in the 2nd year also we went, not only we went to the Maharashtra, we went to the other states, Telangana, Andhra Pradesh and other states also, and probably it may go more in states in this tenure of Dr. Ram Gopal sir. And thank you, Dr. Ram Gopal sir, again, once again, to continue this our journey of general journey with MahaAP. And I thank all the MahaAP dignitaries for that and all the Raigad dignitaries for that. With that, I give my best compliments to our today's presenter, Dr. Avanti, Dr. Sadanand, to present their articles, and all the best for this session. And let us hope that this journey goes a very, very long way. Thank you very much.
Thank you, sir, for giving your blessings and to refresh our memories with the journey. I request Dr. Ram Gopal Chizara, sir, to say a few words of encouragement to us. Over to you, sir.
Thank you, Neha madam. Welcome all the delegates and wish you a happy Doctor's Day. I will not take much time because already we are late. First of all, I congratulate and appreciate the efforts taken by Dr. Hemant Gangolia and Dr. Mohanty sir to start this series, and congratulate them to complete successful 3 years. So great job done, sir. And at the same time, I congratulate Raigad IIP for conducting a successful Mahaniyocon. That was also a super success. So congratulate to Dr. Gangolia sir and Vikas More sir. Over to Neha. We can start. I think already it is 9.
Thank you, sir. Now I request our president, Dr. Vikas More sir, to say a few words. Over to you, sir.
Thank you so much, Neha. At the outset, I am very much thankful to Ram Gopal sir for giving the opportunity, and happy Doctor's Day to all. I am so proud that the journey which began 3 years back, and we are continuing this journey even now. It is just possible because of the successive president allowed this journey to continue, and because it is already late. I am thankful to Mohanty sir and Chitra madam and Neha for being behind this program continuously. Thank you so much. Over to you.
Thank you, sir. So friends, for today's session, we have 2 experts with us, our patron and our very own Dr. Neeman Mohanty, sir. Pallavi ma'am, please share the slides. Professor Emeritus Pediatrics at MGM Institute Health Sciences. He is also member of Academic Council and advisor at MGM. Sir was former DIG Medical and Chief Consultant Pediatrics at CPMF-MS, recipient of Meritorious Service Medal from President of India, and he has over 500 presentations, 65 publications, authored 3 book chapters. We also have with us Dr. Ravindra Sunavne as expert. At present, sir is professor and head of Department Pediatrics at Dr. Vasantrao Pawar Medical College at Nasik, PG coordinator in the same institute. He has been faculty.
Second slide. Yeah.
He has been faculty for many IIP modules. He has penned more than 21 publications at national and international journals. While our presenters for today are Dr. Sadanand Shetty, practicing pediatrician, Chembur. He will be presenting the research paper, Use of Pictograms in the Evaluation of Functional Abdominal Pain Disorders in Children. But before that, Dr. Avanti Prajapate, Junior Resident at Dr. Vasantrao Pawar Medical College and Hospital, will be presenting the review article, Pediatric Malaria, Global and North American Perspectives. So now I hand over to Dr. Avanti. Please share your slides and you can start your presentation. Over to you.
Dr. Avanti? Yeah.
Yes. Good evening, everyone. I would like to begin by wishing a happy Doctor's Day to all of the participants and viewers. Today, I will be presenting a journal based on the topic of pediatric malaria. This article was published in the Pediatric Clinics of North America journal in the year 2022, and it deals with global and North American perspectives of pediatric malaria. The authors of this article were Ella Forgy, Ms. Hannah Brooks, Michelle Barton, and Michael Hawkes. As we all know, pediatric malaria is a leading cause of mortality in children, and this is perhaps the right time to discuss about this topic, as the monsoon season has just started, and this is the time of extensive breeding of mosquitoes. Malaria remains...
Ma'am, can you make it full screen?
Yes, ma'am.
Dr. Avanti, any problem?
Pallavi madam, can you share this PPT?
No, she had done it previously. During trial, she has done it.
Hello? Ma'am,
Okay.
just click on
Just-
the from
just
current slide.
Double tap
Just,
करा.
yeah, click.
From beginning double tap करो. Do double tap, Dr. Avanti. No.
Or in the same
Ma'am, just
line, you
click
see
on
there
the
is a slide
from
show.
current slide.
There is written slide show. उसको click करो. बीच में है slide show.
हाँ सर.
हाँ उसको पर yes. हाँ yes. Double.
Ma'am, just stop sharing once again. Stop sharing your screen. Again, share the screen. Select the window which is with the full screen. Yes, click on the resume. Click on the resume button.
Yeah.
Just click on the from current slide.
There may be one window opening full slide. You select that window, not this one. It will not work from here. Don't do that. Stop sharing, start again. Don't do resume. It will not work. Stop sharing, start again. And when you see the full slide window, click that one. Don't click the other window. Hurry.
Ma'am, click on the resume button. If any problem, I will share it.
Dr. Neha, please share her slide.
Yes.
That will be better.
Dr. Avanti.
Yes.
Thank you, Neha madam.
Okay, Avanti, carry on.
Yes, sir. Thank you, ma'am. As we all know, malaria poses a major threat to child health globally. Malaria is a parasitic disease which is caused by the parasite Plasmodium. Amongst the various species of Plasmodium, Plasmodium falciparum, transmitted through the bite of female Anopheles mosquito, causes the most severe type of malaria. The most deaths due to malaria are caused by Plasmodium falciparum, which is transmitted through the bite of female Anopheles mosquito. This parasite involves two hosts. The life cycle of this parasite occurs in two hosts, namely the human and female Anopheles mosquito. This slide explains the life cycle of this parasite. When the parasite enters the body, it goes to the liver and it infects it has mainly exoerythrocytic life cycle and erythrocytic life cycle. And then as the parasites are released into the bloodstream, it causes febrile paroxysms. Symptoms and severity of this disease are affected by age and immune status of the patient. Few cases of this disease progress to severe forms such as cerebral malaria, severe anemia, respiratory distress, acute renal failure, which contribute to mortality due to malaria. Symptoms of malaria include impaired consciousness, convulsions, clinical jaundice, abnormal bleeding, AKI, hemoglobin urea, severe anemia, hypoglycemia, lactic acidosis, and hyperparasitemia. Hyperparasitemia is defined by percentage of the infected RBCs. Renal failure is a complication which can occur within this disease. It is, however, more common in adult population. That is why this disease is also known as black water fever. Diagnosis of malaria can be made by history of travel to endemic locations and demonstration of parasite on thick and thin smears. In all cases of febrile illness with suspected malarial illness, it is better to go for a confirmed diagnosis with parasitological demonstration. In peripheral blood smears, peripheral blood smears can be of two types: thin and thick blood smears. Thick smear helps in rapid identification of parasites, whereas thin smears are useful in species identification. Another modality of diagnosis is malarial rapid diagnostic test, which incorporate the use of monoclonal antibodies to detect certain plasmodium specific antigens in the blood, namely histidine-rich protein 2 and LDH and aldolase. The drawback of these tests is that they remain positive even after the infection has been cured. Hence, they should be used in complementary to the peripheral blood smears. PCR, that is polymerase chain reaction, is the most sensitive and specific modality for malaria, which can detect species even at low levels of parasitemia, that is 1 to 5 parasites per microliter of blood, and also help to detect resistance to anti-malarial drugs. Now let's move on to the treatment of malaria. Uncomplicated malaria. For uncomplicated malaria, this article describes the use of artemisinin combination therapy. Drugs like artemether, lumefantrine, atovaquone, proguanil, quinine, clindamycin, doxycycline, and mefloquine can be used. Chloroquine is used in areas where chloroquine is sensitive. Severe malaria, World Health Organization recommends the use of parenteral artesunate. One of the complications of this drug is post-artesunate delayed hemolysis, which occurs after 7 to 21 days after the drug has been administered, which occurs due to rapid killing of the parasite, and the lifespan of the RBC is reduced to 7 to 21 days. Hence, the hemolysis will occur at around 7 to 21 days after the drug has been administered. Artesunate is given at a dose of 3 mg per kg per dose in a child less than 20 kg and 2.4 mg per kg per dose for a child more than 20 kg at 0, 12 and 24 hours and continued thereafter at OD dose. The problem in controlling this disease is that the emerging anti-malarial drug resistance is posing a continuous threat. Greatest prevalence is seen in Cambodia. Vector control measures seem to be a better way of prevention of spread of this disease. Use of insecticide-treated bed nets, indoor residual sprays, and mass drug administration and chemoprophylaxis of travelers is better. Insecticide-treated nets are mosquito bed nets treated with long-acting pyrethroid compounds. Other ways of prevention are indoor residual sprays. Or chemoprevention can be done by drugs like sulfadoxine, pyrimethamine combination, and amodiaquine. For prophylaxis of travelers, for short-term prophylaxis, we can use doxycycline, and long-term prophylaxis, mefloquine is used. Upcoming vaccines for malaria include vaccines such as RTS, AS01 and vaccine Mosquirix. However, they have shown only modest efficacy and are still undergoing trials. Travelers should be counseled regarding use of physical barriers like mosquito repellents, chemoprophylaxis. Anti-malarial drug prophylaxis should be advised to travelers. Thus, the malaria control efforts worldwide have seen many setbacks and recent advances. RDTs are a reliable tool aiding early diagnosis. However, they should be used complementary to peripheral blood smear demonstration of parasites. The battle against malaria is far from over, so we need coordinated efforts, chemoprophylaxis, vector control, awareness about the disease, and high index of suspicion with prompt diagnosis and early institution of therapy to prevent mortality from this disease. Let's see the IAP guidelines for malaria. For Vivax uncomplicated malaria, chloroquine and primaquine can be used, and artesunate 4 mg per kg orally or sulfadoxine pyrimethamine combination can be used. In uncomplicated cases of falciparum malaria, we use artesunate at 4 mg per kg orally OD for 3 days, followed by and sulfadoxine pyrimethamine on day 1. Another regimen consists of artemether-lumefantrine combination, which is available in both tablet and liquid preparation. Artesunate mefloquine is also used for this disease. Severe malaria can be treated with artesunate at a dose of 2.4 mg per kg IV stat and then at 12 and 24 hours and then OD. And once the patient is able to swallow, we should switch to the oral regimen. Artesunate and sulfadoxine pyrimethamine in all states is used in India other than Northeast. Artemether and lumefantrine is preferred in Northeastern states. The dose of artemether is 3.2 mg per kg loading followed by 1.6 mg per kg. And once the patient is able to swallow, we can use artesunate sulfadoxine pyrimethamine combination. Thank you. One more thing to remember is that malaria gives rise to severe anemia because of intravascular hemolysis and ineffective erythropoiesis. So the patients treated after cured from malaria should be, we should give them prophylactic hematinics for at least 3 to 6 months after the cure. Thank you.
Now may I request expert Dr. Ravindra Sonavne sir to give his expert comments. Sir,
please unmute.
Extremely sorry. Thank you, Chitra madam. Very well presented by our Avanti Paranjape. So topic was pediatric malaria. That was taken from the pediatric clinics of North America. Impact factor for this topic was 2.1. Generally, up to 3 we say it is a good, and less than 1 say we poor, and more than 10 is remarkable. And I have evaluated this quality of this malaria article. So I asked myself some questions. So how do you feel? So I feel this is a good article. What surprised you? It was only giving focus on Plasmodium falciparum and not on this Plasmodium vivax. What left you confused? They said ki
Sir, we are not able to hear you.
Bluetooth device is ready to pair. Okay. आ रहा है नया आवाज आ रहा है? Yes, sorry. Once again, thanks Chitra madam, and very well presented this article on pediatric malaria by Avanti Paranjape. So this article is taken from the pediatric clinics of North America. Impact factor is 2.1. The actually less than 3, we can say up to 3 is good, less than 1 is poor, and more than 10 is remarkable. So it is a overall good article. While evaluating quality of malaria article, I asked some questions to myself. So first question, how do you feel? So it was a good article. What surprised you? They have focused on only Plasmodium falciparum and not Plasmodium vivax. What left you confused? They said ki RDT first and then followed by the microscopy that will give definitive diagnosis. But in Indian setup, microscopy is a gold standard, and Indian setup having a good microscopy. We will see later on that. And what plays or annoyed you? So they say ki microscopy as this fever is very rare, tropical fever, malaria in North America. So these microscopies are not daily used to diagnose this malaria on a microscopy. So the skill is lacking on that. That annoyed me. And what was interesting, they covered falciparum very well, symptoms, investigation, and treatment. And what was the purpose of this text and what are the intended audience? So audience are in that article was general practitioners and pediatricians. And what was missing? Yes, they have not covered properly Vivax. They have not mentioned about Plasmodium malaria or oval. They have not mentioned definition of relapse or recurrence. And also they have not explained properly, like exoerythrocytic schizogony, erythrocytic schizogony, or gametocyte sexual cycle in mosquito. So they should have mentioned cycle properly. Then the article was overall helpful, then concise, clear, documented, organizing, not so creative, but well researched. So, and content was good, and structure was meeting standards and reaching the needs of intended audience, and writing language was clear and easy to understand. So overall article, in my opinion, was good, with a good evidence and very well justified. I only now what is Indian scenario as compared to the North America, I wanted to say. Now in North America, there is malaria is mostly imported, mainly from the this Southeast Asia or Africa. And but in India, 95% population lives in endemic area. Okay, and there is a delay in diagnosis there in North America due to lack of familiarity with tropical disease. But in Indian setup, many good microscopists are available in periphery or so PSC, RH, etc. Now they have mentioned 22,400 cases in US every year, and almost imported 75% in Africa and Southeast Asia. Now in India, in last, from January to March, there were 18,000 cases of falciparum, and there were 3 deaths. Now India, there are 3 zones. One means categories wise 0, 1, 2, 3. 0 category means totally eliminated. In 2017, there were 28 districts. Now in 2022, 128 districts are almost totally malaria is eliminated, and parasite index more than 2. That in 2017 there were 71 districts. Now in 2022 there are 18 districts. So the vision that is of India, this NSP, National Strategic Plan, is to eliminate malaria 2030. So that is going very well in hand in hand. And in Maharashtra is in category 2, that is pre-elimination phase. Now Lakshadweep and Pondicherry, they are in 0 category, 0 cases, and the Mizoram and Tripura or West Bengal, they are in 3 categories where annual parasite index is more than 2. And in India, there are lots of cases of severe malaria by Plasmodium vivax. They are also we are getting. Then this always you have to remember ki the children living in malaria endemic area, any febrile children, we should suspect malaria. We should do this gold standard microscopy, thin slide and thick parasites. Thick generally they detect parasite loads and response to the therapy, and thin detects the species. They identify species. And in children under the age of 5 years, they are yet to develop effective immune response. So they are susceptible to infections and rapid disease progressions. So we have to concentrate under the age of 5 years, pregnant women. Now symptoms are non-specific. We don't get that classical intermittent pattern below the 5 years of age, cold stage, hot stage, then this sweating stage. We don't get in children very commonly. And it is said कि peripheral smear patient को high fever और Rigers हो गए तो ही लेना चाहिए, तो ऐसा नहीं है. Peripherals, you should not wait for that. Peripheral smear should be taken immediately, and single negative smear, it should not exclude the diagnosis. We should repeat at the interval of 8 hours 3 smears. When we up to 48 hours, when there are 3 negative smears, we can then exclude this malaria. And but what are the disadvantage of microscopy? Sometimes low parasites, they cannot be detected. Sequestration cannot be detected, and in that cannot be detected. And sometimes good microscope is not available. That can be the this disadvantage of microscopy. Then RDT, that is this rapid antigen detection test. It is done by HRP, monoclonal antibody test, HRP antigen 2, then LDH and aldolase. HRP antigen is specific for only falciparum, and optimal test, that is utilizing LDH and aldolase enzyme. It is more specific. It is covering falciparum and other species also. So both this microscopy and RDT should be done hand in hand. Should be done both together. Now the North America article, they have stressed on PCR. It is a very sensitive or specific, but in the Indian setup, this access to PCR is very limited, and it is very costly actually. Then regarding the treatment monotherapy should not be advised. In P. falciparum, there should be oral artemisinin ACT therapy, either artemether, lumefantrine, artesunate, mefloquine, artesunate, sulfadoxine, pyrimethamine, or if mefloquine is not available or allergy to artesunate, quinine plus clindamycin can be used. Above 8 years, quinine plus doxycycline can be used, or autoquinone or prognonil can be used. And this also uncomplicated malaria PYVX, we should give oral chloroquine 25 mg per kg, 15 mg per kg stat, then after 12 hours 10 mg per kg, and then after 24 hours 10 mg per kg, that 25 mg per kg per base, and primaquine 0.25 mg per kg for 14 days. And in P. falciparum, we have to give this primaquine single dose 0.75 mg per kg for gametocidal and suppose this VIVAX, if there is a chloroquine resistance, then we can give treatment of uncomplicated P. falciparum according to WHO guidelines. And in severe malaria, we should use artesunate. US FDA, they're given this artesunate from 2020. पहले वहाँ पे quinidine use होता था. So artesunate rapid recovery, and it is acting on all stages of malaria parasite. And quinine is acting on only mature trophocyte, and side effects of quinine are more hypoglycemia and cardiac arrhythmia. And so artemether dose, below 20 kg, artesunate 3 mg per kg, more than 20 kg, artesunate 2.4 mg at 12 hours, 24 hours. And after patients start swallowing properly, then we can continue this orally for 7 days. And artemether start dose is 3.2 mg per kg. So chloroquine is available by the name Larigo, then primaquine by the evaquine or primacip. Artesunate is available by the Falsigo. Then artemether lumefantrine is available by L-Mart DS. Pyrimethamine sulfadoxine available by Resisnet. And mostly she has mentioned preventions, vector control, insecticide treated bed nets, indoor residual sprayings, and chemoprophylaxis. Chemoprophylaxis can be done by chloroquine or by mefloquine, but side effects of mefloquines are more. And mefloquine can be started 2 weeks before, and it should be continued up to 6 weeks, weekly dose, single dose. And if they are allergic, best is atoquinone, proguanil, that can be started at the day of departure. That is the atoquinone and proguanil. And traveler to India already covered this. And this, already mentioned ki malaria, that is most common in July to November season. They are thrive in 20 to 30 degrees Celsius and humidity 60 degree. And these malaria parasites, Anopheles mosquito, they breed more in edges of streams, water tanks, overhead tanks, etc. And we should not give malarial treatment, anti-malarial treatment empirically. We should do the microscopy and RDT, and then we should start these drugs in combined therapy, because there are resistance. Drug resistance is very common, and even insecticides, we should combine 2 insecticides with a different mechanism of action should be combined for an indoor residual spray to avoid insecticide resistance. So, and in G6PD, mild G6PD deficiency, we can give 0.75 mg per kg weekly primaquine for 8 weeks. If there is a problem with my primaquine, you can give chloroquine 10 mg per kg weekly for 3 to 6 months. And there is one more entity, tropical splenomegaly syndrome. In that grade 3, grade 4 spleen occurs in endemic zone, and we get high IgM malaria antibodies, and we treat with this chloroquine or primaquine prophylaxis for lifelong. If there is no improvement after the 6 months of primaquine, this weekly prophylaxis, we have to do splenectomy, and these tropical splenomegaly patients die with secondary to bacterial infections. So actually, and cerebral malaria should be differentiated with meningitis and encephalitis, and algal malaria should be differentiated with meningococcemia and gram-negative septicemia. And severe malaria, already it is covered. Unconsciousness lasting for 30 minutes, convulsion more than 2 episodes in 24 hours, hypoglycemia, blood sugar more than 40, metabolic acidosis, serum bicarb less than 15, then this severe GIT, bleeding, renal failure, creatinine more than 3 mg, then prostrations, weakness, then respiratory distress, acute pulmonary edema. These are all complications of this severe malaria. So this is regarding the scenario in India compared to the North America.
Thank you, sir. Thank you very much for that elaborative treatment protocols. We are thankful for that. Malaria, dengue, and rainy season in tropical countries is the usual experiences which we practitioners get. But with starting of rain in our part of Navi Mumbai, we are getting virals with vomiting, loose motions, and abdominal pain. And for this topic, we have chosen a successful private practitioner from Navi Mumbai to present our second topic of discussion. Over to Dr. Sadanand. Pallavi ma'am, can you please share his slides?
Good evening, madam. Good evening, sir. Good evening, all the dignitaries. So today we will be discussing about a journal article, Functional Abdominal Pain Disorders in Children. Now the topic for the journal is the use of pictograms in the evaluation of functional abdominal pain disorders. This is from the Journal of Pediatrics, volume 263, December 2022. So the author being Clara et al. Now, chronic abdominal pain, the prevalence is very common, not only in Indian as well as European setup. the prevalence is as high as 10 to 15%. So how will pictograms help? And what is this functional abdominal pain? Now, when we talk about abdominal pain, when we talk about functional, in medicine, we have been taught that anything functional is psychiatric, like maybe somebody is mimicking. But in our pediatric case, functional abdominal pain doesn't mean that the child is mimicking or it is a psychological pain. Rome 4 criteria has classified these functional abdominal pain disorders in 4 subtypes, mainly functional dyspepsias, irritable bowel syndrome, functional abdominal pain, and abdominal migraine. Now, this functional abdominal pain is not otherwise specified. So how do these pictograms help as a tool? Now, when we talk about pictograms, they help in overcoming the barriers between the patient. No, I want the same slide. Yeah. The pictograms help as a tool to reduce the barrier between the patient and the healthcare providers. At times, the child cannot express where exactly the pain is, what kind of pain the child has. And these pictograms will help to guide us what kind of pain it is. Also, it helps better in the symptom assessment and to evaluate the symptom complex. Yeah, next slide, please, madam. Now, when we talk about this study has certain objectives which shows the effectiveness of evaluation of pictograms in pain assessment and classifying the types of functional abdominal pain disorders. Also, research methodologies have been used to evaluate the same. A questionnaire has been formed with about 19 questions in this journal article. Now, the journal article also talks about the pathogenesis of functional abdominal pain. Pathogenesis mainly involves visceral hypersensitivity, GI motility abnormalities, altered gut microbiota, and brain-gut axis. So as you all know, there are no specific markers. For liver disorders, we have LFT. For kidney disorders, we have RFT. But for functional abdominal pain, only USG may catch only structural things, may catch perforated appendix, may see air fluid levels on X-ray. But silent or subtle biomarkers are not present, which will suggest that it is functional abdominal pain. So the aim of our current study is to evaluate whether use of pictograms really improves the symptoms for evaluation for children. Next slide, please. Now, in this study, we basically have taken 2 centers in Netherlands and Belgium, and the age group of children is between 8 to 18 years. Patients who have been in OPD with abdominal pain have been assessed, and the assessing year has been from April 21 to March 22. The exclusion criteria are also very clear. Concomitant organic GI diseases have been excluded. Insufficient knowledge of native language have been excluded, and those who were not able to perform the assessment of pictograms were excluded. Now, how was the design of the questionnaire? So 19 questions were framed, and each question was run with the help of healthcare workers. So these questions were based on Rome 4 diagnostic questionnaire, and also the Bristol stool scale was considered as a standard. So basically, the findings of nausea and vomiting were found to have pictogram benefits, whereas other symptoms were not found to have any benefit. Next slide, please. Now, when we talk about, we have already discussed about this, the pathogenesis of functional abdominal pain, wherein it is multifactorial, not a single factor is involved. The brain-gut axis, the visceral hypersensitivity, the GI motility disorders, and the altered gut microbiota. Next slide, please. So when we talk about pictograms and the patient comprehension, they really help in the measurement of outcomes. The primary outcome included was the level of agreement, overall agreement. The second outcome was agreement on abdominal pain symptoms, while the third was nausea and vomiting symptoms. So there was improved comprehension with the help of pictogram only in the age group of 8 to 12 years, and more so for nausea and vomiting symptoms. Overall agreement on other symptoms was not much. The concordance level were not much. Also, agreement on abdominal symptoms was similar. Next slide, please. So basically, assessment tools, 2 groups were made. one group wherein pictograms were shown and the other groups wherein pictograms were not shown. And then these two groups were compared with the questionnaire given to one groups along with pictograms. So it was reliable and valid assessment tool, and even Bristol's stool scale was taken as a standard. Next slide, please. So what was the result in this study? So t-test were run and t-test and Pearson X2 test was run, and it showed that except nausea and vomiting, all other symptoms were similar in both age groups, 8 to 12 years as well as 12 to 18. Also, other functional abdominal pain, overall agreement, there was not much difference. So, taking into account nausea and vomiting, symptoms accompanying explanatory pictograms were beneficial with good concordance rates. Thus, pictograms can help as effective communication strategies. But when we compare the same study with studies done in adults, which was by Tack et al., it is seen that Tack et al. Group has shown significant help when use of pictograms was done. Concordance studies were high. So what was the reason for such concordance rate? In our study, only yes or no type of questions have been asked, whether pain is there or not there, whether nausea is there or not there. But in adult study, they have done a scaling from 0, 1 to 5. That's why this was the major difference in the Tack study and our study. Also, when we talk about overall agreement, in adults, it was seen that their cognition and their assessment of symptoms is more sharp, and that's why they can easily pick up things. Now, when we discuss about concordance rate, it had improved for evaluation of nausea and vomiting, whereas in all other groups and all other symptoms, it was almost the same. So to sum up, not only pictograms, but good history taking is also important, as history taking is cornerstone of any child coming with abdominal pain. Sometimes patient comes to our OPD. Parents tell नहीं, जब भी बच्चा स्कूल जाना होता है तभी उसको पेट दर्द होता है, जब भी बच्चे को ट्यूशन भेजते हैं उसको पेट दर्द होता है. When we see the abdomen is very soft, non-tender, no hepatosplenomegaly, no nausea, no vomiting, nothing as such. So in such cases, history is important. We evaluate, and on evaluation there is nothing. So this kind of patients also we get in our clinical practice. Now, as regards our paper, pictograms can serve as effective communication strategies. Higher studies with larger scale number of patients. Here the number of patients was about 120. Maybe different centers can be taken, more number of patients can be evaluated. And as in the adult studies, along with pictograms, they had done scaling. Maybe some studies could be done wherein 0 to 5 scaling can be done, and we could further evaluate such things. This is all this from my end. Thank you, madam. Thank you, sir.
Thank you, Dr. Sadanand. You please now stop sharing, and Mohanty sir, please give your expert comments.
Thank you, ma'am. I must thank Dr. Sadanand. Very lucidly he had presented. This is a difficult topic. I can understand. Why? Because we are not very conversant with functional abdomen pain. Abdominal pain is very common with children. Say about, as he said, about in our OPD, about 5 to 10% of our patient children, they complain of abdominal pain. And in gastroenterology OPDs, about 25% of patients will be abdominal pain only. So why this is a problem in children? They don't perceive the abdominal pain, where from it is coming, what is the nature of the pain. And the functional, he has nicely said, what is functional? It is not that the pain is not there, he is feigning. No, pain is there. In a milder form, he is perceiving it in an exaggerated manner. Because his hypersensitive gut makes him to perceive that mild pain or minor difficulty, discomforts, very exaggerated manner. And one is that hypersensitive gut, because it is innervated by the unmyelinated C fibers in the gut. And from the gut-brain axis, there is a defect. So they transmit this pain in a very speedy manner So this pain is also exaggerated. This is combined effect. The children, they perceive this pain in a different manner. Functional, in a visceral pain, and what is pain is very dull in nature. They will tolerate very well this pain. They are not screaming or rolling on the ground. It's not a very acute like organic causes. This is from visceral. But when when this parietal pain, it is painful, and the little movement of the child will perceive more pain because this uh, parietal structures, when they come in contact with each other by movement, the pain is exaggerated. So you can differentiate a dull aching pain, which is not very serious type. It is from the viscera, and the other is from the parietal pain. So functional abdominal pain usually is from the viscera. And what is the presentation of functional abdominal pain? He has said, I will just clarify this. Mostly when they are more than 5 years of age, they can express. That is, I have pain, I have difficulties. This pain, if it is coming at night when the child is sleeping and gets up with the pain, it cannot be functional. It is organic in nature. But if he doesn't complain while he is asleep, if his pain when he goes to sleep, there is no pain, it could be functional. So this is their ways and means how to differentiate between the organic cause and a functional cause. Functional abdominal pains are paroxysmal in nature, interfering in normal activity of the day-to-day activities. It can be epigastric, periumbilical, infraumbilical pain, which he has shown in the pictograms. He has forgotten to show those pictures you should see. And it is nearer the umbilicus. Very importantly, all our pediatricians, please remember, when the child shows where the pain is, if you ask him the location of the pain, always they point to the umbilicus. Wherever the pain is from, they will point to the umbilicus. Right? This is a embryonic cause behind it. All this viscera, they develop as a midline structure in the center, and later on migrate to different locations. The nervous system and the nerves, which is coming from this viscera, they come and join the spinal cord in the middle line, and maybe 3 or 4 segments higher than this viscera, they join the spinal cord. So the location of the pain is differently perceived. It's not exactly how the adults feel the pain. Children, they are perceive it differently. The Rome 4 criteria says the 3 episodes of pain in last 8 weeks qualifies it to be functional abdominal pain. It is episodic, it's not the continuous manner. Episodic, 3 episodes at least in last 8 weeks, that even 2 months. If there are 3 episodes or more, it is functional abdominal pain, and these symptoms are free for intervals. No corrective measures, meals or bowels in pattern. There is no pattern. A normal physical examination and laboratory reports are non-productive. You can't get anything in examination. That is why we said functional. He's not feigning. He is having that pain. That is functional abdominal pain. So this is the thing I must wanted to let you know. The functional abdomen pain is 80% of the pain abdomen in children. So what we are seeing in our OPDs, they see pain abdomen, 80% are functional, only 10% or less are organic in nature. So we should take lot of time, because there is no clinical marker to understand. There is no, he has already very well, he said, Dr. Sadanand, there is no marker, you cannot do a blood test or x-ray to know this cause of the pain. No, only the history may help. But the history is the main thing you have to do. And there, when the history is not helpful, that the pictorial diagrams helpful. So there are pictures of children showing different regions. Somewhere the fire is burning in the epigastrium, or there is a pain marked in the hypogastrium, or see in the diphisternum, or say in the umbilical region, or in the iliac fossa, whatever. This pictorial region should be done, and you ask the child to show where it is the pain. So he may not show in his own body, but he will be able to show it in the picture, seeing the picture of a spasmodic in nature like a rashi, or spasmodic pain है. If some fire is burning, this is a burning pain है. So these things suggested in that pictures, pictorial diagrammatic pictures will help them in a better manner. These kind of studies is worth doing in our own setting. It is very interesting to know the result that they have done the Europe. Why I selected this probably a very interesting topic. If you say only 5 children with your all our IP Raigad, Maharashtra IP in our pediatricians, 5 children you contribute with the pictorial diagram. Dr. Hemant will send them the pictures to all
Yes,
of
sir.
them. If you are interested, can send them.
Yes, sir.
Use them and see how these concordant with their complaint, whether it's coinciding with this pictorial diagram and their history or not coinciding. If they are coinciding, as that study says, only nausea and vomiting is coinciding, others are not correlating. Maybe we may find it, the finding may be different. So we may publish it. It will be very interesting. So please think about it. Thank you.
Yeah, before we end, I also wanted to thank Chitra madam and Mohanty sir. In spite of their busy schedule, they helped me to prepare for this slide presentation. And without their help, it wouldn't have been possible. So thank you, madam, and thank you, sir.
Next, Adharan, do you have that picture with you now?
Yes, sir.
Sir,
Show that.
we are still in the program, Dr. Sadanand.
Yes, ma'am.
Dr. Hemant sir wants to give some comments, as
Yes.
well as then Dr. Minaj sir.
Yes.
Thank you, Dr. Chitra madam. Yes, you should not say thanks before Sadanand doctor, because we are still in the program. Because I would like to say 3 or 4 things. First of all, Dr. Sadanand, the presentation was very good, but I have not seen any pictograms. So probably you must have included 4 or 5 slides what really pictograms mean. And though we use at periphery, probably not. And so we would have loved to see the pictograms showing what was the
No, he has prepared. He has just forgot it.
so he could have shown that. That would have been better. That's one part. Yes, really. Let us see. Then one more question. That question I will ask Dr. Niven Monti sir afterwards. Before that, I would like to speak on the malaria. Dr. Avanti, how much of malaria now we see? Last year I do not know how many, and this year also now it is. We have said the monsoon started, and what Dr. Sonani sir suggested, yes, the gold standard is microscopy, but still at periphery, we do find very difficult to have the pathologist or the skilled lab technician to see the malarial parasites on the slides. Literally speaking, my area of practice is also very periphery, though it is near to Bombay, 87 kilometers, but still we prefer rapid test, antigens test, which is still I will prefer. I do not know, though it is maybe cost little bit costlier than. So I don't know, but still we follow, because though it is said in rural hospitals and near PSC, because I know all the status of PSCs what are around my area. So it is not so good to say that, but still at least okay, we agree to that. But still, I feel the rapid test antigen is the most reliable ones to do, but with a reliable company offering the kits which are having, now I forgotten what that enzymes are there, but definitely which are very 100% sure about it. The question to first Dr. Sadanand or Dr. Mohanty sir may, as an expert, he may answer.
Sir,
Though we are though we are saying functional abdominal pain. So these are why I'm asking. We are thinking that case to be a functional abdominal pain, but what are the chances that we are really missing the organic one, which may land up into disaster, and probably the methodology of investigation required in such functional, though clinically we are maybe sure of clinical, but medico-legally probably it may cause a problem. It turns out to be, if we miss something, it's going to be disaster, and probably what the investigation is to be done to just confirm it is not a organic one.
Sir, so in our journal, they have clearly mentioned that the exclusion criteria is concomitant, structural, GI disorder. And clinically, we can assess whether it is surgical abdomen or it is non-surgical abdomen. If it is surgical abdomen, then it is out. The question of functional is out. Again, if it is non-surgical abdomen, we have to run test as X-ray abdomen erect, USG abdomen. As sir had mentioned, history is very important. When the child had passed stools, when the child had passed gases on the clinical side. On the lab side, we have tests like LFT, RFT, liver enzymes. Again, we have other tests which will suggest involvement of pancreas. And if required, if all this fails to pick up the cause of abdominal pain, then maybe scopy or CT scan also may help. Sir, if I have missed anything, you may please add.
No, you have done very well. I have 1-2 points. This is a functional abdominal pain. This is excluded. Organic causes have been excluded. Now, I will 2 or 3 things I will tell you, and one must rule out organic causes. It is criminal not to rule out organic causes before you certify it as a functional pain. What are the indications are? Usually they are less than 5 years of age, whereas functional is more than 5 years of age. It is associated with constitutional symptoms like fever, vomiting, weight loss, a growth retardation, joint pain, rash in the organic causes. Vomiting, bilious vomiting, blood-stained stool, or pain awaking at night from the sleep, what I said earlier also. The pain, as it is away from the more it is away from the umbilicus, it is more to be organic. More close to the umbilicus, it is more likely to be functional. It can be dysuria, hematuria, flank pain, family history of acute acid peptic disease or IBD, perianal diseases. All these things we have to take in the history to rule out the organic causes. Very important, as Dr. Sadanan said. We must rule out first. It's a medical legal, sir. Is the expert in medical legal. We are should be very cautious to label a child as functional unless you rule out with all possible investigations or clinical examination history taking to rule out functional the organic causes.
Thank you, sir. Dr. Minash Seth.
1 minute, Dr. Chitra madam. Dr. Ravindra sir want to comment something.
Yes, sir.
Dr. Minash Seth.
सर तुम्ही म्हटले की याच्यामध्ये मायक्रोस्कोपी पॉसिबल नाही. तुम्ही नॉर्थ अमेरिकेचं स्टँडर्ड फॉलो करताय. तिथे आयडीटी हे पहिले केलं जातं, नंतर मग मायक्रोस्कोपी केली जाते. तर तिथे मायक्रोस्कोपी नंतर का केली जाते? कारण तिथे तेवढा इन्सिडन्स नाहीये. ते ट्रॉपिकल फिवर हा मलेरिया रेअर आहे, त्यामुळे तिथे स्किल नाहीये. पण आपल्याकडे भारतामध्ये स्किल आहे, पण लोकांना वेळ नाहीये. 20 मिनिटं सर जर मायक्रोस्कोपी करायची असेल आणि त्याच्यातून जर मलेरिया पॅरासाइट डिटेक्ट करायचं असेल तर 20 मिनिटं लागतात. 100 ऑइल इमर्शन फील्ड हे तपासायला पाहिजे, जे की कोणालाही वेळ नाहीये. मेन कारण ते आहे सर. आणि आरडीटी मध्ये सर, आरडीटी मध्ये पण आहे ना, ज्याच्यामध्ये एलडीएच आणि अल्डोलेज आणि एलडीएच हे एन्झाईम असतील, ती का टेस्ट केली गेली पाहिजे. कारण एलडीएच डिफरन्शिएट बिटवीन व्हायबल अँड नॉन व्हायबल मलेरिया पॅरासाइट. जे हिस्टिडीन रिच प्रोटीन आहे, दे कॅन नॉट डिफरन्शिएट व्हायबल और नॉन व्हायबल पॅरासाइट. 28 दिवसापर्यंत पण ते मलेरिया पॅरासाइट मेल्यानंतर पण ते HRP पॉझिटिव्ह असतं. तर त्यामुळे ऑप्टिमल जे मी नाव घेतलं कंटेनिंग एलडीएच आणि अल्डोलेज ते केलं गेलं पाहिजे. आणि मायक्रोस्कोपी हे गोल्ड आहे. जसा सोन्याचा भाव जसा वाढत चाललाय तर
Sir,
yes sir.
One line I will say.
Yeah.
Say this article is it is written that it is relevant to North America and all those Western countries. This is not applicable to us. But we wanted to know what is happening in that side part of the world, how they are doing it, what the medicine protocol they are using. That's all only.
Yes sir.
Just to have a knowledge. Otherwise, it is not applicable to us. Secondly, I am an old timer. I passed MBBS in 1970. हमारे टाइम में पैथोलॉजी डिपार्टमेंट में एक मलेरिया पैरासाइट देने के लिए एग्जामिनेशन में मिलता नहीं था. They were taking it from the northeast of Assam. So many places they were searching. The malaria was not there. So maybe a good news is coming to us. We are going to eliminate malaria. That's why you are not getting malaria cases here.
Yes.
In
Yes,
one
sir. Yes, sir.
time, New Bombay was falciparum belt and the chloroquine resistant belt. See, we are not getting malaria cases now. So we are in the way. It's a good sign that we are going to get rid of this malaria menace, and this is a good thing. And
Yes, sir.
yesterday only we heard about the malaria vaccine. It is nothing to be said about it. We don't think confirmed malaria vaccine is going to come to us so fast. And about the microscopy, and microscopy is the gold standard. If you do not train your eyes on the microscope, I have been doing microscopy in my OPDs in the CRPF. So unless you do that, you will not be able to do it. You don't train your eyes, you will not see. What mind doesn't know, eyes will not see.
Yes,
Over a period of time, our doctors will cease to recognize malaria because you don't see, or eyes will not be trained. So that's why you continue training your eyes. Thank you.
Dr. Minash Sheikh, your comments, short
Well,
comments, please.
well, I've short. Good evening. I joined late, but whatever I could understand is that two things. The things are very clear independently. Either we are working this part of that part of the world. It does not mean they don't have skill. It does not mean that we don't have knowledge. They have the best of people. So we have. Number one. Number two, I agree with the gold standard is microscoping. And the best microscopy that I have seen in my life is the PhD technician.
Yes.
They are the one who will teach us and show because they actually keep on doing. I agree with Ravindra that you need some time, and time is money, so we don't spend on it. That's with regard to malaria. Number one. Number two, we cannot disregard the point of care test. There are two only point of care tests which has been recognized by the government of India in the health program. Number one is NS1 antigen, and number two is this malaria rapid test RDT. So two RDTs are recommended by the government of India. One is NS1 antigen, and second is RDT. I agree with what is Ravindra has said. HRP and LDH, they are recognized by the government of India. So we cannot disregard those tests also. These are with regard to malaria.
No, it should be confirmed.
With regard to functional abdominal pain, the things are very clear. The things are very clear. Functional means we have 100% ruled out organic causes. And I have just posted one Rome 4 criteria. We can go through this criteria. Things are very clear. So I totally agree that, we have and the only thing that what Mohanty sir has said, we need to train ourselves with regard to heart, mind and eyes all together. Thank you from my end.
Thank you, Minash sir. Sadanand, you wanted to have some comment?
Madam.
You wanted to
Actually,
show
Hemant sir had
that-
made a very good point that we need to rule out all other things. I remember one 10-year-old child. This child used to come for abdominal pain, was given course of oral antibiotics, nothing on the nothing on the USG, nothing on the test. But afterwards, I even seen a pediatric surgeon. But as such, pediatric surgeon also didn't feel clinically there was something. So afterward, this child saw adult surgeon, and adult surgeon did a scopy. Now endoscopy. So endoscopy showed that early peptic ulcer disease. So that is how the point which we need to take, which Hemant sir has made. We have to rule out all other things before we label it as functional.
Sadanand, one more interesting addition to this is, you have to rule out epilepsy. One of the presentation of epilepsy is abdominal pain.
Yes.
So we have to rule out. So when we talk about abdominal pain, we have abdominal functional and organic, abdominal, extra abdominal. And extra abdominal start from brain and everything.
Yes.
So not many a time, but sometimes we do get epilepsy presenting as abdominal pain, and EEG will be positive.
Abdominal epilepsy is mentioned in this article
Yes.
also.
Yes.
Sadanand, will you be able to show that picture?
Sir, we will post it on our Raigad IIP and Maha IIP channel.
Okay.
That picture was not there in the slide. I have an apology for that. But that can be posted in the channel separately along with this episode. And happy to announce that.
Madam, one thing.
Yeah.
Regarding pictogram, you can make one PDF, Dr. Sadan, if it is possible. You can circulate the groups also. No problem.
We have a pictogram in another slide. We will try to share that.
Yes.
On page
Sorry,
3.
madam.
Yeah.
I will try.
Shall I proceed?
Yes, madam.
Yeah. Our next 1st August interested medical college is Government Medical College Yavatmal and HOD Dr. Ajay Keshwani. And I want to invite and I want her to speak also Dr. Mamta ma'am, who is a lecturer and who is interested in 1st August journal journey. Our topics will be adverse environmental exposure and respiratory health in children and sudden unexplained death in children. Dr. Mamta?
Hello.
Yeah.
Hello everyone. I'm Dr. Mamta Khandale from Yavatmal. On 1st August, I will be presenting journal in journal journey.
Yeah, thank you very much. Thank you, ma'am. Pallavi ma'am, any questions in your YouTube?
No, ma'am. No questions.
Okay, final comment from Dr. Gangolia sir about the working of journal journey. We are entering 4th year now.
Nothing specific. We are going very well. Just it's very nice to see that you are very well in advance planned. Everything, articles all ready. Just only same thing. Whatever the convener of MAHAIP is there, if he gets in touch to decide the all remaining 5 months of this year or 6 months of this year, then it will be better. So as to plan properly. That's all. I think since everything is going fine.
Yeah. May I invite
and madam, you are doing wonderful job. Just
thank you, sir.
we are
Thank
taking
you.
practice sessions and it's very wonderful. It's a
Thank
very
you
difficult job, but you are taking hard.
We are proceeding towards the end of this session, and I hope everybody has enjoyed the lively discussion about the common topics of functional abdominal pain as well as malaria. I really want to know from Minas Sheikh sir, how much malaria is there in the metro city of Mumbai?
One comment that it is not that it is not been there. It is there. Only thing we have to be careful. And it's not that rampant, but I must say the malaria is more common in the area, the paddy growing areas. So if you go to areas like Bandara, Gadchiroli, Chandrapur, you will get the first diagnosis is malaria. I remember once the government deputed me to Gadchiroli when there was malaria epidemic, a malaria outbreak, not epidemic, outbreak. And I remember still those days, every PHC you go, every district, the hospital that you go, the technicians were solid. They used to say, "Sir, देखो ये malaria का ये stage है, ये stage है, ये stage." I still remember that thing. And number one, number two is that in those endemic area, you can practically get every presentation of malaria. I agree with some of the speakers that they have said that it may not be relevant and prevalent in that part of the world, but still it is prevalent in our part of the world. And our part is not always metro. We live in, India lives in villages. India lives in, small cities. So that is what we don't have to forget. We have to accept and understand all these things which is relevant to us.
Yeah, thank you very much. And it's time for Thanksgiving. May I invite Raigad IFP Secretary Dr. Ajay Kori? Is he there? Okay. Thank you very much, MAHAIP President Dr. Ram Gopal and Secretary General Dr. Amol Pawar for allowing us to continue with Journal Journey. We also thank Raigad IIP President Dr. Vikas More and Dr. Ajay Kori Secretary, our main brain behind Journal Journey, Dr. Hemant Gangolia sir and Dr. Jay Bhandarkar for starting this Journal Journey for the Raigad IIPians and then taken over by MAHAIP. I also thank this episode's expert, Dr. Mohanty sir, who is our mentor and painstakingly spend hours in the library to find out the articles which are helpful for general pediatricians like us. Thank you very much, sir. I also very much indebted with the interest shown in this article of malaria to Dr. Ravindra Sonavne sir from Nashik, and he has elaborated the treatment for all of us. The presenters, Dr. Sadanand Shete, has taken out his valuable time to present here the article of functional abdominal pain, and the best and the youngest presenter, Dr. Avanti Paranjpe from Nasik, was on duty and still contributed for the presentation of this interesting article of malaria. The backbone of this episodes of Journal Journey, Dr. Neha Singh, who is instrumental in circulating the flyers as well as the write-ups. A big thank you to her and good night.
And a big thanks to Dr. Chitra Kulkarni madam, who moderated the session wonderfully. Thank you, madam, for that.
Thank you, Chitra.